lot of yesterday only.
We are going live now.
Okay.
Give me 1 minute. Give me 1 minute. Yes, we are live.
Good afternoon, ladies and gentlemen, all viewers of this Pro Series webinar of the Association of Spinal Surgeons of India. I welcome all members of the Indian Orthopedic Association who are watching this webinar, all members of the Association of Spinal Surgeons of India, and all those viewers from all across India and the surrounding countries who are joining us. Today, we are having the second part of the webinar on lumbar disc herniation. The first one we had on May 24th, and during that webinar, we discussed basic issues connected with lumbar disc prolapse, such as how to diagnose clinically a lumbar disc prolapse. We discussed the clinical diagnosis was based upon radicular leg pain, paresthesia, numbness or weakness in a radicular distribution, and positive nerve tension signs such as SLR, femoral stretch test, cross leg, straight leg raising test, belt test, and slump tests. We then went on to discuss the natural history, and it suggested that most patients improve on their own with a little bit of help from the doctors and within 6 to 8 weeks. 90% improve within 3 months, and then only 4% more improve over the next 9 months or so. A lot of patients go through the natural non-operative treatment, but some patients wish to go forward with prolonged non-operative treatment beyond 3 months. This can be tried in patients with pain alone and those who wish to avoid non-operative treatment or operative treatment. The limitations are that the success rate for relief of pain significantly drops after the 3-month period. There is a significantly higher risk of chronic back pain and dissatisfaction and a lower rate of return to work. The non-operative treatment was discussed at great depth, and it was decided that the most common non-operative treatment followed by most panelists was a short period of bed rest of 3 to 7 days. NSAIDs plus analgesics were given. No role of IV steroids was found. Epidural steroids and root block injections were certainly things which were administered. Along with the short period of bed rest, activities within limits of pain, exercises within limits of pain were started early in the disease. However, return to work is only allowed after significant relief of leg pain. And emphasis was that traction and belts have no role to play in the modern treatment. Generally, with this kind of non-operative treatment, 25% of the patient's radicular pain resolves within 1 week. About 50 to 60% pain relief is there in 2 weeks. It takes about 80% to get of pain to go down in 1 month and 90% over 2 months or so. The surgery, unless it's an emergency surgery, the only emergency being an acute cauda equina syndrome, which we will be discussing today, but generally treatment is within 48 hours. We will be also discussing the problem of significant motor weakness, whether we should operate early or late or not at all if the patient presents later. But mainly patients come with pain, and here it is a shared decision between the patient and doctor as to when we should operate. Pain is basically on if the patient has pain on failure of non-operative treatment, that is the indication for surgery. Chances of neurological recovery after surgery are about 50 to 70%, but similar chances of neurological recovery are there even with non-operative treatment, though probably with surgery the recovery is marginally better and earlier. When you talk about surgery, there are a lot of general orthopedic surgeons watching this program. And the key is that the goal of surgery is decompression of the neural structures. This may involve disc prolapse, discectomy, and it may involve decompression of the root in patients who have accompanying lateral recess or central stenosis. The goal is to do minimum surgical damage to collateral damage to structures which are not essentially which are not essential to be removed during surgery. So surgery can be a fenestration, a hemilaminectomy, a laminectomy, and sometimes, occasionally, a fusion may be required. Fenestration is done usually at L4-5, L5-S1, sometimes at L3-4 also for a typical posterolateral disc. Hemilaminectomy is typically useful when there is a migrated disc, when there are conjoint nerve roots, when there is a lateral recess stenosis along with this thing, and maybe sometimes for a large central disc also. A laminectomy is typically used in an upper lumbar disc prolapse, a disc prolapse associated with a severe central canal stenosis, a disc prolapse which is large central massive disc herniation, you would think of doing a laminectomy. Fusion is very rarely necessary. It is only when you can demonstrate instability pre-op, or you created instability by excising the whole facet intraoperatively. How can you do this surgery? You can do the surgery open, conventional method, or you can use minimally invasive techniques which involve using a microscope, which is called a microdiscectomy. You can use a microendoscope, which is a tubular retractors, or you can do what is now called as a total endoscopic approach, which can be done either transforaminal or interlaminar. The key message we gave you was that the decision is more important than the incision, and patient selection is the key. Mid-term and long-term outcomes are similar with all the various techniques. 85 to 95% success in leg pain relief. Minimally invasive surgeries tend to give you immediately post-surgery less pain, possibly less intraoperative blood loss, and a shorter hospital stay. Today, in part 2, we are going to discuss specific situations in lumbar disc prolapse, case scenarios of large central disc prolapse, far lateral disc prolapse, acute cauda equina syndrome, disc prolapse with stenosis, disc prolapse with or adjacent to a level of spondylolisthesis, and similar such stories. So without much ado, let me welcome our the person who's going to moderate the session, which is our president of the Association of Spinal Surgeons of India, Dr. Chabra, and our panelists from all across India, experts in their individual cities and well recognized across the globe. Dr. Upendra from Bangalore, Dr. Sailesh Hadgaonkar from Pune, Dr. Arun Bhanot from New Delhi, Dr. Arvind Kulkarni from Mumbai, Dr. Shankaracharya from New Delhi, Dr. Rishi Khanna from Coimbatore, and Dr. Soumajit Basu from Kolkata. We also have a couple of other guests on our panel, which we are happy to have, Dr. Bharat Dave from Ahmedabad and Dr. Abhay Nene from Mumbai. So without much ado, let me stop sharing my screen and give the screen to Dr. Chabra and welcome him and ask him to take this forward. I would also like to request all of you that if you have any questions on any aspect, all these panelists and myself are waiting to answer the questions. I will also put these questions to the panelists. Please direct the questions to my WhatsApp number, that is 9820504351. I repeat, my WhatsApp number is 9820504351, and I will put these questions forth to the panelists. Thank you.
Thanks, Gautam. Welcome once again to this second part of the webinar on management of prolapsed intervertebral disc. Thanks, Gautam, also for giving the introduction. I will not repeat, but just try to reinforce some of the points which were discussed last time in a few minutes. We talked about the very common condition, prolapsed intervertebral disc, the significant prevalence and incidence of it. We talked about how it represents a degenerative process. We talked about the high economic impact for both for back pain and for prolapsed intervertebral disc. We talked about the typical presentation with unilateral leg pain, usually in a particular dermatome, and with pain increasing on walking, coughing, and sneezing. but we also talked about atypical presentations which may be there. With regard to the pathophysiology, we talked about two schools of thought for the failure: primary annulus failure or primary end plate junctional failure. Clinical history and examination being the most important components for a diagnosis, reinforced by a radiological evaluation. In the absence of cauda equina syndrome, we discussed that the initial treatment should always be non-operative, that is, conservative treatment has a big role and can result in significant improvement in a large number of patients. We talked about the goals of treatment: early return of patient to their normal activities, to avoid unnecessary surgery, efficient and precise use of diagnostic studies, and to devise a treatment format that will make therapy available at an acceptable cost to the society. We talked how bed rest should be limited, if at all it has to be implemented. We also talked about how we could go stepwise from a multimodal conservative therapy. Some people choose to give transfemoral epidural steroids as an intermediary before jumping onto surgery if they don't respond. The main indication for surgery being failure of conservative treatment, and the only absolute indication being cauda equina syndrome. Shankar talked about, Gautam talked about the timing of surgery. We discussed the various modalities also, and we discussed how tubular endoscopic discectomy may have a lot of advantages, but you have to choose what works best in your hands. So this is all that we discussed, right? And all this as well. But we have a lot still to discuss in this today's webinar, as Gautam also pointed out, and we will now set the ball rolling. I want to thank once again all the panelists who are here, and of course Gautam for having coordinated everything. So with that, want to mention that last time we had a discussion on a case of a recurrent disc herniation, but because of want of time, we had to go about it in a hurried manner. But since this is a common condition with an incidence of 5 to 15%, and some people claiming it as one of the commonest complications following primary discectomy, I thought we could spend some more time on it. And Upender also wanted to raise some points. It would be important to point out that it is defined as ipsilateral or contralateral disc herniation also. So if you operate on one side, even if it is the contralateral disc which herniates, it will be called as recurrent disc herniation at the same level after a pain-free interval of at least 6 months since injury. And this poses some challenges like epidural fibrosis and scarring, wound-related complications and infection, segmental instrumentation instability. If is there, it then puts the need for instrumentation, the psychological impact for the patient, and sometimes also the surgeon, and the economic impact. They could not find any correlation with age, gender, BMI, level and site of disc herniation when it comes to the risk factors as well as occupation. But smoking, diabetes, and protrusion are risk factors which have a positive correlation. Also, high incidence of facet tropism has been seen in recurrent disc herniation. Less facet orientation angles, high range of motion, high disc height index, lumbosacral transitional vertebra. These are the radiological parameters which have a high risk, which have been found to have a high risk of recurrence. And now, how do you go about evaluating a case of a recurrent disc? Contrast MRI would be ideal. And since scarring enhances heterogeneously because of its vascular supply, and since retraction of the thecal sac towards an anterior epidural soft tissue lesion is suggestive of scarring, these are points that you could see when you look into a recurrent disc herniation. Upender wanted to make some points, so over to you, Upender. Unmute yourself, Upender. Yeah.
Thank you, sir. Thank you for this. So I just wanted to say that lot of literature with a wide range of different disc. We see the literature. So though these are different literature, we have a lot of. Does this move, sir? Can you do it or
Yeah.
you will? Yeah. So because of lack, consistency in recurrent discs and the longitudinal studies, there have been population studies of less bias. So there are very large and they have actually been seen across nations. So I just took up 3 of them, one from the US, one from the Finnish National Registry, and one from the South Korean registry. Surprise, most of them, like here it is 13,000 patients, here it is around 35,000 patients, and around 18,000. And all of them give almost similar rate of reoperation. Mind you, this is reoperation. They don't mention that it is exactly all the recurrent discs were included in this. Recurrent discs which were reoperated. So it is around 12% here, 14% and 13.4%. So it's around 4 years, 5 years and 10 years follow. You have a significant amount of patients with a single level discectomy going in for a recurrent disc operation. So can I go to the next slide, sir? Thanks. So if we see what type of operations we do for these, again, there have been instances where there is second reoperation after a revision surgery. So most of these who see as recurrent herniations, we offer them revision discectomy, where we don't find too much of stenosis or rigidity. But if you see, surprisingly, these patients who received re-discectomy surgery, who received lumbar fusion at a rate of around 38%. This is quite, even mentioned last time, it was too high to accept actually. So within 4 years, they were receiving 38% were receiving a fusion surgery for a re-exploratory discectomy. This is quite high. Next, if I can go to the next one. Similarly, this US study, if you go to the Finnish study, for the 35,000 patients, they saw that 14% reoperation, 0.3% had 2 reoperations in 10-year follow-up. Now, saw that the risk of a reoperation was reduced if the first reoperation took place more than 1 year. So if you have a recurrent disc more than 1 year after initial discectomy, you're slightly safer. So if you have a recurrent disc patient coming to you within 1 year, you need to start discussing a second reoperation also significantly with him, because these are quite large data we are seeing. And also, if the first reoperation was a fusion, they have found it low risk. And if the 50 to 64 years, so that is more than 50 years, a younger patient has a higher risk of revision resurgery. So, yeah, so once we discuss all these things with the patient, usually what we do is we discuss in detail about the possible options, including the fusion for a recurrent discectomy. So a revision surgery, usually a recurrent discectomy is still a preferred solution. However, we need to explain the chance of a second recurrence. So we do consider fusion in all these patients. We discuss with them. Pain, one of the important things, we fall in favor of a fusion for a recurrent disc herniation. And obviously, if there is instability, we go in for fusion. Now, the problem comes if the patient does not accept a second recurrence. Now, we need in front of us and he will be asking, what is the guarantee that this will not happen again? So we have to be honest with him that we do take out the disc again and we decompress, but there is another chance of recurrence which might not be very significant, but you have to accept it. So all these things, I think we should discuss in detail. So a recurrent disc patient who is requiring a surgery is not a simple patient who is coming with a first disc. So we need to discuss all these issues in detail. Otherwise, the patient will be coming back for a second recurrence where he will be quite angry with us. And also we will be feeling quite sorry with him. So these are the few points I wanted to make. Thank you for the opportunity, sir. Over to sir.
Thanks, Upendra. Somajit, in your point of view, would you always offer or would you always discuss a fusion surgery for patients who come to you with a recurrent disc herniation and need a surgery?
Always discuss three issues with the patient. The first is the honest submission that you again have a 10 to 15% chance of recurrence, just as I say in the first surgery. That's the honest submission. The second issue to be considered is how much of back pain and how much of leg pain, and what if you cannot sacrifice one for the other. How much would you be satisfied if I can take care of only of your leg pain and not your back pain? And the third issue are radiological issues. For example, if there is a tall disc height, if there is a demonstrable facet trophism, if there is additional stenosis, and if there is a demonstrable instability. So all these three issues put together, I will go ahead with the decision.
Dr. Chabra, sorry to interrupt. There is a question from the audience.
Right.
What is the role of non-operative treatment in a recurrent disc situation?
So can I take up this question?
Yeah, sure.
Yeah, sure. So going with the same going on the same cue, the question of operating or non-operating is a very careful and, if possible, a repeated discussion with the patient. And what really matters is the honesty of your submission based on your own experience and the available literature. Dr. Chabra.
Yep. Anybody else has a point? Arvind? Yeah, Shailesh? Unmute yourself.
Yes, good evening, everyone. I think it's a very valid question that can we treat this patient non-operative? In everyone's life, when this patient is operated by yourself and when it is operated by someone else, we have to understand the retained disc, we have to understand residual and recurrent. Three things. When normally a patient comes to you, when you have operated, you normally think that I did a very good job and probably this is a recurrent disc. When it is operated elsewhere, it's a human tendency that we feel that probably it's an incomplete evacuation or decompression of that particular fragment. Sometimes the surgeons keep that fragment, if he is taken out the big fragment, he retains some amount of disc. So we have to be most important, very, very clear about this, that the patient will be patient and no one wants a second surgery. So giving a second chance is always better. We definitely have to take this as you have done the surgery for this patient, whoever it is coming from, and can we give a best option like anti-inflammatory medications, maybe a pain block. That can be a big answer, and a lot of time these patients do settle with pain blocks also in case of symptoms, and probably we can avoid surgery. That's one additional point I just thought of sharing, sir.
Thanks, Shailesh. In my practice, I always gave conservative treatment at trial, except in the absolute indication of Cordite-Foyner syndrome, and many of them would respond to a conservative treatment protocol, whether it's a primary disc or a recurrent disc or a failed back. So anybody would tend to differ from the panel on this?
Dr. Chabra, again, I am calling Dr. Gautam here. Question from the audience. Dr. Faisal Khan from Aurangabad has asked the panelists, are there any predictors of recurrent disc herniation?
We just talked about that, Gautam. We talked about the risk factors for smoking, diabetes, protrusions, and facet tropism, less facet orientation angles, high range of motion, high disc height index, lumbosacral transitional vertebra. These are those where there is a high risk for recurrence. Soumyajit also gave a reference to this when he talked about. So
Lovely.
anybody has anything else to add? If that satisfies,
Yeah, I think so. This was very, very clearly outlined. Thank you.
uh, so see, when it comes to a recurrent disc, also what I would want to point out that you can manage them endoscopically as well as open or a microdiscectomy, right? That's clearly there in the literature, and I think your experience also mentions that. Upendra, I would want to also draw the attention to this meta-analysis where they found that even though there was division rate seemed to be slightly higher in the discectomy group as opposed to the fusion group, but the difference was not statistically significant. And we also need to consider that when you go in for a fusion, you will have a larger operative time, blood loss, overall cost, complications, and failed back incidence increases also with that. So you need to draw a fine balance, as also suggested by you. There was this other meta-analysis also review where they found out that discectomy would give as good result, if not better, than a fusion surgery with a recurrent disc herniation. We will now come to this case of a 46-year-old male who complained of low back pain with right lower limb radiculopathy, leg pain more than back pain of 6 months duration, normal neurology, SLR right side positive, and could walk hardly 20 meters. You can see the disc here. Now, has failed conservative treatment, and what would be the management in this case? The patient has failed conservative treatment. So, anybody here, Rishi? Have we lost Rishi? Rishi, would you want to?
Rishi, can you unmute
Here,
yourself?
Rishi. Meanwhile, Arun, would you want to?
Can I have a look at the MRI just once more?
Yeah.
So it's a recurrent disc with a paracentral as well as a foraminal component, right?
Primary disc.
It's a primary disc.
Yeah.
So if it's a primary disc in 6 months of failed conservative treatment and it's a dominant leg pain. So if the patient agrees that I am okay to seek primary treatment for leg pain, then I would focus mainly on discectomy rather than on any fusion in this patient.
Right. Fine. Anybody tends to differ? So we gave him still selective nerve root block, right? Conservative, we consider nerve root block as an intermediary between a conservative and surgical, and the patient responded to that. There was another patient, right lower limb radiculopathy in a 49-year-old male, primary leg pain, pain in right L5 distribution. There was a EHL weakness 3/5, walking distance less than 50 meters. SLR was positive. These are the pics. Mind it is L5 pain. So, nerve root block didn't give much relief, and the patient wanted to move on. So, what would you do? Anybody from the panel? Arvind?
Yeah, so we need to know whether there is any lumbarization of S1 here.
No lumbarization.
So it is possible for disc herniation at this place to cause L5 pain. There is a good amount of incidence of an overlap between L5 S1 and L4 5. The L5 root might get You might get L5 symptoms with a L5S1 disc herniation, seemingly L5S1 disc herniation. So if your conservative treatment at the same time, the L5 would be exiting at this particular region. So it could be trapped in the foramen, in the extraforaminal area at this particular level. You need to check another few axial sections.
Right.
So it is easily amenable for a laminotomy and discectomy. Using whichever technique we use.
So considering that it may be the extraforaminal component which may be causing the L5 nerve root pain, you would go the routine way, or?
Yeah. So in this particular case, you have very big facets. So even if you cut half of this L5S1, facet joint here, you'll be able to still reach the extraforaminal layer very easily.
Okay, anybody in the panel, when you have an extraforaminal presentation, for example, are there any special considerations, any special presentations in extraforaminal discs, or is it routine like any prolapse intervertebral disc? Anybody?
The extraforaminal disc usually is much more exquisitely painful because it irritates the dorsal root ganglion,
Right.
and therefore patients are in such exquisite pain that they are unable to tolerate the non-operative treatment for very long.
Right.
If they hold on to the non-operative treatment and if they are able to tolerate the pain for a little bit, then the results of non-operative treatment are equally good.
Right.
But if they can, it is difficult for them to hold on. That is the problem.
Yeah, Arun?
There is a higher incidence of dysesthesia in these patients if whether you treat them conservatively or even with surgery. There is a longer period of dysesthesia in these patients which lasts for more than average for regular disc herniations.
Fine. Shankar, do you have any other point?
I still believe that it is a straightforward posterolateral disc herniation rather than a extraforaminal disc.
Fine. Considering that it may be the extraforaminal component which may be causing the problem. Okay. So if you consider foraminal and far lateral disc herniations, we still have 7 to 12% of them presenting like this, generally in their mid-50s, predominantly L4-5 and L3-4, occasionally at L5-S1. The exiting root radicular pain is generally there. And importantly, you will see neurological deficits in a high percentage of cases. Up to 75% cases will have deficits. As Gautam said, you can manage them conservatively as well, and you could manage them successfully without surgery, as was brought out by this meta-analysis. And as Gautam said, because of chronic compression of the dorsal root ganglion, you can have a significant neuropathic pain which may be persisting even after you operate. So you have to operate them early for a better outcome. So that also becomes a bit important. And you can manage them in various ways. You could manage them by medial facetectomy or intertransverse approach. You could do a full facetectomy. And here again, you may not cause clinically relevant instability even with a full facetectomy. And fusion is not required in a large number of cases. Then you have the posterior extraforaminal approach and the posterolateral muscle splitting approach also, which could be there. And MIS approaches tend to work well for extraforaminal or foraminal discs. And amongst the MIS approaches, tubular microscopic discectomy works better as per this meta-analysis. So Shankar, over to you for your presentation on far lateral disc. You may share your slides now. I will unshare.
Okay, thanks Chavra. Thanks Gautam for inviting me for this seminar. And my job is to talk about far lateral disc herniation, extraforaminal disc herniation. And I will quickly go through. I think most of the slides have been spoken about by Chavra already, but just for completion's sake, far lateral compartment is the compartment between the two pedicles, extra to the two pedicles. And so just where this comes from, where the nerve root comes out and you have the dorsal ganglion, and it is just leaving the exiting the pedicles or exiting the vertebral body is a compartment. It's a tight compartment because of the intertransverse membrane, and because it is a contained area, you can get a lot of severe pain, burning, dysesthesia, as everyone has already said. So. So this is a typical far lateral disc herniation or extraforaminal disc herniation, and it is extra to the foramen, so that's why it is called. The most common level is between L4 and L5, L3, 4, and the incidence is about 7 to 12 lumbar discs, and about 6 to 5 to 6% of all disc surgeries are far lateral disc surgeries. So it's not a very uncommon, though in our routine practice we may be doing 1 or 2 a month or even less than that. Typically, as Chavra said, that they have extreme radicular pain and very little back pain, and they have burning and dysesthesia, and the leg pain is unremitting. They actually hold their leg flexed, and they said it is burning like hell. And they are present with positive femoral stretch test, iliopsoas and quadriceps weakness, and dimness, knee jerk, and proximal sensory changes. So it is important to keep these things in mind, and sometimes they can be presenting higher up also at L2, 3 and L1, 2. Typically, this diagram tells you how the exiting foramen gets trapped and the traversing foramen escapes. So at L4, 5 level, the L4, this is, so this L3 nerve root gets affected, while in the normal posterolateral disc, if the L3, 4 disc prolapse and L4 nerve root get affected. So typically when we have an L3, 4 disc prolapse, we have an L4 nerve root affection, while you have, if I have an extraforaminal disc, we have a L3 nerve, the same exiting nerve gets affected. Dr. Chavra just spoke about various approaches, the microdiscectomy approach, the transforaminal endoscopic approach using, and you have the tubular retractor approach. I've been asked to show an open intertransverse intramuscular approach, and I'm going to take you through a video. This approach was described by Professor Wilsey, and he is also the first one to describe interestingly the use of methyl methacrylate to put prosthesis in the bone, and also described a Wilsey pedicle screw system. So he is quite a versatile surgeon. I was reading his history, and he also the first person to describe the paraspinal muscle approach. So this approach is paraspinal. It is between the multifidus and the longismus, and is about 3 centimeters away. And this is all the same approach we use to do our percutaneous screw fixations, and the lateral trajectory for the tubular retractors also. So you can mark the level by an from the MR. You can calculate how far it has to be from the midline. It's usually about 3 centimeters away from the midline. And this is the plane through which you go between the multiple. And the advantage is obviously there, that it is a short learning curve and you directly reach the disc. This is the place where you reach when you are reaching between the transverse process, you have the intertransverse membrane, and this is the area you have to target where the nerve comes out. There are different techniques as you can approach the disc, far lateral disc in various ways. And Chavra has already said you could do a medial, you could do a fascectomy, tilt the patient over and then take out disc from far lateral, or you could do a complete facetectomy and then take out the disc, both internal and outside the foramen. But these will need fusion procedures and you unstabilize the segment. And so that I think for a far lateral extraforaminal disc fusion should be reserved for a small group of patients. There is quite a large number of complications with extraforaminal disc because of recurrent disc herniation, nerve root injury, and paresthesia and dysesthesia, because the approach has to be learned well. I'll tell you the approach. I'll show you a picture and a video. This is a 60-year-old businessman. He had severe left leg pain and paresthesia for 4 months. This is the picture which I showed you a little earlier on the left side. So this is the X-ray. The flexion extension, there is no instability in this patient. So we plan to go to, because the amount of disc is quite a large. So you can see this medial, lateral, and you go 3 centimeters away. The caudal you can see, and the cranial you can see. And so I've cut the dorsal lumbar fascia. There are 2 layers of the fascia. As soon as you see the muscle, you can find the plane. You put in your fingers, you find the plane. So this is 3 centimeters away from the midline. And you have a small fat pad there. And as you negotiate in this fat pad and put your fingers there, you find that medially you have the facet joint and laterally you have the transverse process. So you keep going. This is an open approach. I use the normal mustard retractors, and the Gilpey retractors is what I use most of the time. And this is the plane I'm going in. So I'm feeling for the transverse forces below, transverse forces above, and the superior ascending facet and the lateral margin of the facet. So I reach the intertransverse membrane here. Then once I reach the intertransverse membrane, I find my landmarks. It's very important to get your landmarks correct. Sometimes you may have to drill the superior facet. And once you get your landmarks, you make your check with an image that you're at the right disc and the right level. So as you do on your transforaminal discectomy, you check your needle. Similarly, here you check your needle that you were just touching the superior facet of the inferior vertebra. And that is your starting point, the junction between the superior facet and the transverse foramen and the transverse process. And this is where I denude the bone, and I see the membrane. And this is distal to the nerve root. Sometimes I use the McCollin retractor also if I have a problem. So just for a better view, I am doing this, but most of the time I manage with the 2 Gilpey retractors. But for the video and for a better presentation, we use this here.
Shankar, while you are showing this retractor, I had a question.
Yeah.
I've always found the Gilpey and the McCulloch to slip a little. I've used for far lateral disc approaches. I find using the tubular retractor much better. It stabilizes. Is that your experience? Have you used that?
Yes, I've used the tubular retractor also, and I've used the Matrix expandable retractor. So that also works very well. And but this has been shot in the microscope, and the exposure is better. But I agree with you completely that the tubular retractor in the far lateral works very well, and you may reach the space quicker also. Here it does tend to slip. So as you can see that on the medial side, which is jutting out, is the superior facet, and that is the transverse process. So I am clearing that area between the junction of the transverse process and the superior facet. And this is the intertransverse membrane. Then that's the intertransverse membrane. And now, and the nerve is far above near the superior pedicle. This is near the inferior pedicle. So here I can easily cut my intertransverse membrane, and then the disc should be there. So once your ligament is exposed and you can feel the facet, if you have to go more medially, you actually can drill the facet. And I've done it many times when I have not been happy with the amount of dissection that I have, amount of disc that have come out, and I think there is a retained fragment. So this is for people to see. I'm trying the transverse process. So this is the transverse process. That is the end of the transverse process. That is the junction between the transverse process and the membrane. And this is the place where I will put my knife and cut transversely. So I'm cutting the intertransverse. It's quite a thick membrane. And this is where we normally used to put our bone graft. As soon as you, so since there's a lot of pressure, you can see the disc coming out immediately under pressure. And this is a large disc which will come out. You can cut the membrane even more, but you don't have to go completely till the end of the transverse process. Medial half of is enough. So once I have seen the disc and I'm to the superior side of the intertransverse membrane is the nerve root coming out. So you have to be a little bit careful, or you can injure the nerve. So that's the disc coming out, which we saw in the MRI. It was a very large disc, and the patient was in severe pain. After taking out this fragment, if you still feel that there is some more fragments left, you can actually use the burr and then drill out the outer surface of the facet and then go a little medially to the pars. Once you reach the pars, your landmarks are much better, and then you can take out foraminal disc or even medial to that. So this is a typical Wiltshire approach for a far lateral disc herniation. I would feel, then I would actually see the nerve also slightly up. And then once I am comfortable with all that, my operation is more or less over. And so that's the approach. If we have time, I can show you another case, or if we don't have time, I'll exit. Gautam?
I think, Shankar, we should move on because unlike last time, we don't want to get delayed because of lack of time. So can you unshare your screen and let Dr. Chabra come back on again? While this is happening, Shankar, there is a question from the audience, and that is, suppose you go in there, not for a far lateral disc, just a routine posterolateral disc, and you find that the disc is calcified. What should you do? And number two is, disc may be okay, but above the disc, there is a large bony osteophyte. So what do you do in these two circumstances?
Gautam, this is not uncommon that you go and do a normal routine discectomy and you find that the disc is hard, it's calcified, or the fragment which you are looking is much more medial or superior to your calcified. And it is very important at this moment of time to take a nerve root retractor and protect the nerve. And then I use a small osteotome actually to cut through the hard calcified disc, and then I go into the disc space. Then I use my nerve hooks and other things to get the normal disc out. And so I have no problem in using an osteotome and cutting the calcified disc. Sometimes the calcified disc may also be very medial, and that may be a challenge. In those cases, I would tilt the patient significantly over, make sure that the nerve root, it is very important to protect the nerve root because it's very common to get the nerve root damage in these cases.
What about a hard, big osteophyte lying just below the nerve root?
I use the Kerrison rongers also sometimes to take out those osteophytes, if I can.
Do the chances of reformation of these osteophytes?
There are chances of reformation of the osteophytes, and that's a problem. So I wash them out very well, and that's also very important. And in some of these cases, I put depometrol or steroids.
Right. I think we hand the mic over back to Dr. Chabra. Dr. Chabra, there's one question from the audience, and that is the role of annular repair after doing a discectomy.
Right. So anybody would want to answer that? Rishi, are you there?
Hello?
Yeah, Rishi, go on.
Yes, there are a few studies which have demonstrated how to perform an annular repair following a microdiscectomy or a discectomy through the annulus. But the recurrence rates have been uniformly similar whether we do a repair or not. So it has not been popularly followed now.
Have the incidence of recurrence reduced after annular repair?
It's the same, sir. It's between 10 to 15% whether we do a repair or not.
Can I ask a question, Chavra, to Rishi? How do you repair the annulus? Because my only experience on repairing the annulus was some demo kits which were given to me by Medtronics, which had staples which were
Yes,
viable
yes.
many years ago.
Similar to that, sir, that there are annular clips available which we use to, if it is a cruciform incision, it is difficult to repair. If you have made either a transverse or a vertical incision through the annulus, then the ends can be approximated after the discectomy and then we apply the clip. I don't have a personal experience, but the literature, that's what is shown.
What about laser annuloplasty, which some of the endoscopic Arun Bhanot could answer that question?
So nowadays we don't use laser, but the radiofrequency flexible cautery that we use in endoscopy, some surgeons do recommend doing what we call as radiofrequency annuloplasty, which is not a mechanical repair, but they try to shrink the annulus using the radiofrequency after removing the disc. It is not comprehensively proven to reduce the rate of recurrence, but it may play a role in reducing the incidence of annulus origin back pain in these patients.
Yep, vote for that. Shankar,
Yeah.
one question. This was a far lateral disc, right? Suppose there is a foraminal disc, right? Would your approach be different?
Now, in a foraminal disc, I would look at the far lateral component. If it is a foraminal disc, I normally go from the standard approach, and then as long as the facet orientation is all right, I could tilt the patient and take out the foraminal disc. It's only in this extended far lateral disc where the disc component is very significantly large, and then the patient has typical features of dysesthesia, burning, and all sorts of far lateral disc symptoms. Then I would go use the Wiltse approach. As I said, I use probably 5 or 6 cases a year of Wiltse approach, not more than that.
Yep, but the only thing is many times you club them together, FEF, LDH, foraminal and extraforaminal lumbar disc herniation. Why is it so?
Why do you club both of them together? I don't think they should be clubbed together, though they present together because they are an extended spectrum, because the approach for both of them is same. But however, sometimes you can take out far lateral disc prolapse by tilting the patient and going through the standard approach and taking out half of the facet. Then also you can pull out the disc, far lateral disc. So that also is possible.
Anybody from the panel? I think one of the reasons may be that both of them can cause compression of the dorsal root ganglion and can be very painful. So their presentation is similar. Their approach for a surgical treatment may be slightly different. So,
Dr. Chabra,
yeah,
I think it depends on the thickness of the pars.
right.
So upper lumbar levels where the pars is not so thick, either foraminal and extraforaminal discs are the same.
Right.
Lower down at L4, L5S1, the pars is very wide. So you'll get a foraminal component and the extraforaminal component separately.
Yep, and Arvind, most of the times it is predominantly at L4-5 or L3-4 and very occasionally at L5S1 or the upper lumbar disc herniation. So, fine. So we move onwards. Now you have considered typical cases where you have a typical presentation of a disc prolapse. Suppose you have a disc prolapse at multiple levels. How do you go about deciding when the patient fails a conservative treatment, if you need to go in for a surgery? How do you decide which level to address? So this was a case, 41-year-old male, left lower limb radiculopathy in both L5 and S1, was 7/10. Low back pain was less than this. This was 6 months of duration. Not responding to a good conservative treatment. Neurology was intact. The canal is also slightly narrow at L4-5 and L3-4, but now if this patient comes to you with an L5 and an S1 left-sided radicular pain and has not responded to a conservative treatment, will you address both levels, all 3 levels, 1 level? How do you go about deciding in this regard? Can we first ask, say, Chalish?
Yeah. If the patient is symptomatic and all the conservative treatment is not helping, do you mean that you're given a pain block also for this diagnostic as well as therapeutic? whether it has been done.
That is the point here. That you struck the nail right.
Yes.
You give a selective nerve root block, right? And if you say a root block, you can give by various measures. But if you give it at L5S1, which addresses both the nerve roots, and if you get relief, then probably L5S1 is the level that you need to address. And we have been using this, and we have got good results. In this patient, only L5S1 discectomy was done, and the patient improved with the L5 and S1 left-sided radicular pain. Anybody from the panel has anything else to suggest?
May I say something, sir?
Yeah, sure.
So, when we talk of selective nerve root blocks, I usually in multiple level would suggest to do a staged blocks if you have a doubt.
Right.
Second, if you have to do, let's say if you said L5S1, so if you suspect S1 root is the cause, then it is better to block the S1 root in S1 foramen rather than at L5S1 foramen, because that will block both the roots and your pathology may be arising from both the levels. So then you treat only L5S1, whereas your L5 root is getting irritated at L4-5. So it would be preferable to do the nerve root blocks in these cases in their own foramen rather than at the level of the disc.
So, Arun, I take it the other way, right? You are blocking the nerve.
Right.
Whether you block it at L5S1 or L4-5, if you block the nerve and you get relief, how would that make a difference? You know that the L5 nerve can get irritated at the L5S1 level also.
That can then, but then that will be getting irritated when you have a foraminal component. If your L5 root is getting blocked at L4, getting irritated at L4-5, and you block it under the L5 pedicle in the L5S1 foramen, you can have a relief from pain, but the source is somewhere else.
But if you block the L5 nerve, you will get relief whether it is getting irritated at L4-5
exactly.
or L5.
So if you are using it as a therapeutic, then you can do. But if you are wanting to take it to a surgery subsequently, then it can create a trouble.
Still, whether you are doing it for a diagnostic, how does it differ, right? Because whether the L5 is getting irritated at L4-5 or L5S1, it will get relief if you block the nerve. Anybody from the panel has anything else?
It will get relief, but the surgery will not be targeted to L4-5 later on. You'll miss it. That's what I'm saying.
So I tend to differ, Arun, but anybody from the panel has anything to suggest in this regard? Yeah, Arvind.
This is not a very typical case. This, it is very easy in this particular. Looking at the MRI, I would just go on L5S1. But hello?
Yeah, L4-5 also, you would say that there may be some involvement in the lateral.
More on the right side, actually. The right root, you can see it is getting squeezed in the lateral recess at L4-5. Left side, I think it's more or less not very difficult to pick up L5S1. I can pick up, just L5S1 left side, to decode.
I put it another way, Arvind. Can an MRI truly indicate which of the discs is culprit, right? The other way, we have had patients in whom there was only S1 pain and no disc could be seen at the L5 level, at the L5S1 level. And we gave a block at L4-5 where we could see the disc and the patient got a relief of the pain.
Yeah, so if
right. We addressed the L4-5 pain and the patient got relief. So an MRI can't just be the only indicator on which level to address, right?
No, so what I meant to say was, provided you see the same amount of compression at two levels, consecutive levels, then it is very tricky.
Right.
So yeah, so there again, you cannot depend on these root blocks. The solution can seep up and down. You cannot, when you counsel the patient, you can't put your hand on your heart and say that this is the level I'll operate and you'll get better.
No, yeah, you have to always give a guarded prognosis that either I address both levels at one go, or if I address one level, there is a chance that you have residual pain and I may need to address the other level subsequently. How do you go about it, Arvind?
So there have been occasions where I've done two-level disc herniations. It's very tricky in such situations where there is significant amount of disc herniation at both levels, and you can't just judge which one is the compressive element.
Gautam, do you have any suggestion?
I can't, sir.
Yeah, just Gautam, after Gautam. Yeah.
No, I think The key thing is your clinical examination, and the clinical examination should correlate with your MRI findings. That is the most important thing that is there. Honestly, sir, if you ask me, I would not operate on this patient at all. There is nothing here. This is bound to, surgery will eventually fail. Patient will be unhappy. In my experience, these type of patients. But the question from the audience here, I would agree with Arun that we should give a root block, selective root block, in order to be able to identify which is the painful nerve root. Now, which pain is the painful nerve root? In this case, I would prefer to give an L5S1 root block on the left side in order to identify whether this is the painful level or not, if I was to give, but I would not think of any operative. For me, this patient is a conservative treatment patient, not a surgical patient. If I operate on this patient, she will make my life miserable. And the additional question I had, which is being asked for, is that what is the role of EMG nerve conduction study in identifying the culprit nerve root in multiple level disc prolapse?
So, Soumyajit, would you want to answer that?
I think before that, if I may be permitted a minute, this is regarding this confusion about discs, multiple level discs. I really do not have a lot of situations in which—
Can you be a little loud, Basu? Can you be a little loud?
Yeah, I have hardly ever got a situation in which more than one disc at any one point in time was the culprit. Mostly, even in spite of radiological evidence of multiple disc prolapses, it is one root which is the symptomatic root, and the clinical skill, as Gautam said, is a must to identify which is the pain generator. Second important thing is regarding the confusion of root block levels. As Dr. Chabra correctly pointed out, if you are treating root block as therapeutic, there's no point in doing a quote-unquote selective nerve root block. Whereas if you're planning for surgery and if you're wanting to target which level you're going to decompress, a quote-unquote proper selective nerve root works. And thirdly, regarding Gautam's statement that of this particular disc, if this is a large disc and a large free fragment, it is more likely to resolve by itself. Whereas this is a small disc just underneath the root, just between the subfacetal region, where it's more of an annular bulge and a disc under pulposus underneath that. These are patients who do not have a lot of spontaneous resolutions. Now, regarding EMG and CV, I do not think that they have any role in pointing out the selectivity of affection. All their role is to distinguish between polyneuropathy.
Very true. So if you have to rule out between a neuropathy like a diabetic neuropathy and a preganglionic lesion, that's where the role lies. Otherwise, it would not have a role here. Now, I will put this question in another manner to the panel, right? How many of you have seen patients where there has been a very small disc and the pain has been excruciating? And on the other hand, have seen patients where there is a huge disc but a very small pain. So you would have seen that very often. Anybody hasn't seen that from the panel?
Yeah.
So you can't just derive the management plan from the MRI picture, right? It has to be a clinical presentation per se. And everybody would tend to differ here because this is a tricky situation, but whether you block the L5 nerve root at one level or the other, ultimately it is the nerve root which you are blocking, right? And whichever level it is getting affected, the pain will be relieved because the nerve is getting blocked. So that is what my take is. We may tend to differ, but in the interest of time, we need to move on. So Gautam, we are coming to the participant poll here.
Yes.
So it's a 54-year male, history of acute onset bilateral foot drop since 10 days, bilateral leg pain, no back pain, no history of bowel bladder involvement, motor power in both L4, 5, S1 grade 0, sensations reduced by 30% in L4, 5 and S1, perianal sensation present, voluntary anal contraction absent. This is the picture. This is the MRI. You can see that it may have sequestered upwards. What will the next line of management be? Surgical management, epidural steroids, comprehensive conservative management, or give all options to the patient. So this is a participant poll, but till as they respond, we discuss this within the panel. So I think within the panel, nobody would have any doubt. Most of you, all of you would say surgical management. Anybody against that? But the trick then comes if this patient presents to you after 6 weeks with a painless foot drop, right? Comes to you at 6 weeks, right? Would you go in for surgical management or manage him conservatively? This is the next participant poll, but
Dr.
I think
Chavra, can you show the images again? Thank you.
right.
Thanks.
So I think Upendra also wanted to make some points regarding delayed neurological deficit, and we'll let him do that and then have a discussion on this. Yeah, Upendra.
Yeah, thank you, sir. I just wanted to make a few comments on the neurological deficits. So say like, I've just taken one case here. We usually go for conservative in the first visit without deficits. If say a patient comes a week later with the same pain, but a significant deficit in the ankle and EHL. So how are we going to manage them? Sir, sorry, again, the next, yeah, thanks. So we have to answer the patient questions here. So we have to inform will improve with conservative and how much it will improve with wait for it. Most of the studies or the reference take is from the Weber study and Herniation study. Sir, the next the studies we take into consideration where we say that if we do surgery or if we do not do surgery, the rate is all 70 to 80% recovery with the Weber study and 50% recovery rate with Herniation study. Now, if you closely look at this, when it shows there are a few drawbacks in this, and Weber himself has suggested the drawbacks when we go study. So the next slide. So even though they included 280 patients, they had 14 days of observation inside the hospital, and they took only 30 and 31 operated non-operated patients into the study. And also they used a motor power testing, which was different from the MRC guidelines. And slide, please. I just want to show you the, yeah. So if you see, they mention the results based on the total number of measurements rather than the number of patients. And also they have patients who had severe deficit, that is less than 2/5. That is more than 80% weakness, and in them surgery actually worked. So these limitations were actually mentioned in the discussion by Weber. The surgery was more than 2 weeks, and it was only the study of mild deficits. So that is why they got 70% improvement in all these patients. So he himself has told that if surgical decompression can be performed immediately after the paresis has occurred, this should be considered adequate therapy till new evidence indicates another procedure. So when we mention Weber, take into account that they have actually suggested an early surgical decompression for a significant deficit. So then when we go into the Herniation study, the next one, sir. So here it's actually a 76-page article, if you can see that. So they have also not mentioned if it is a very significant deficit or a mild deficit. They got the paresis was improved in 53% in operated and non-operated 45%. And if you see the results of an early operation, that is just at 60 days, that was, a late surgery was considered after 60 days and early surgery was considered before, 60 days. There again, they got a better result operation. So when we mention these studies for, defending our for a conservative management, I think we should take consideration that early surgery has been these studies. So now if we see studies after 2000, say like the Postachini study in the next slide, sir. Yeah, if you see these are the first two studies which I mentioned. If you see after 2000, there have been a lot of studies, even Indian studies, say from the Ganga, from Dr. Rajshekar, and they also mentioned that the recovery rates are quite good, from around 76% to around say 96% in a trial where they did surgery within 48 hours of presentation of a significant deficit. So here we can see that even if we operate at 40-45 days, the amount of recovery is somewhere between 60 to 70%. And if we operate early, they have actually given quite a high rate of complete recovery, that is around 96%. But this is a single study. But at least we can take inference from this that there is maybe around 70 to 90% recovery in a significant deficit if we do a early surgery. So the next slide, sir. So what we can probably discuss with the patient is if it is a severe acute deficit, say like less than 2.5, probably the recovery rate is somewhere around 30 to 40% without surgery. If we do a early surgery, it is around 70 to 90%. I think we should give this information to the patient. Next slide, sir. So the problem comes if the deficits are delayed. Now we have a few studies which are mentioning that after 60 days or 70 days, there is absolutely no improvement in the neurology. Yes, we have to be very guarded in giving any patient a surgical option, say after 2 months of a significant deficit. But however, there are studies which even from Dr. Rajshekar, which says that mean days which they took was around 40.4 days. Even with that, they had a recovery rate of 69%. That is quite interesting. And they mentioned that it might be multifactorial and surgery should be offered even in delayed presentations. So it's quite an interesting narrative review. I think we read through it. They that you should have surgery for a severe neurological if it is a onset. So how much again we need to consider and actually tell the patient that we are doing further tests and probably we have lesser chances of it with the amount of time we delay the surgery. That is what we can convey them.
So what is the definition, Upendra, of early acute or subacute deficit, where you are recommending early surgery? Should it be 2 days, 5 days? What is the duration?
That's what. So early surgery, what they are recommending is just like in Corda-Equina syndrome, if you do it within 40 hours, they have given almost 96% of complete recovery, significant. That's quite interesting. So if you do it after the recovery rate, it comes around 80%. That is what the 330 patient study is, again a cohort study, a retrospective cohort study. We still don't have a class 1 evidence on that, but these are quite encouraging. To probably we can treat any significant off the roots just like Corda-Equina syndrome.
Thanks, Indra. We also have been doing some literature search in this regard, and even with a painless foot drop, people have found that you can give them a chance with surgery even if they present late. And if you can, there have been other studies which have also shown that the recovery could be there even if you go in for late, even up to 6 months. So now this question comes back to the panel. If a patient presents to you with a foot drop power 1/5, 6 weeks after the deficit, would you offer surgery or would you say no, please go in for conservative treatment? Anybody who would say go in for conservative treatment and just defend it? Yeah, Shankar?
Go for conservative because I cannot though what Upendra says seems very interesting that even after late surgery people recover. I have also seen after no surgery people recover, and there is no prospective study saying that painless foot drop who have been treated with conservative treatment and painless foot drop treated with surgery, the difference I'm not sure. Upendra can update me on this.
Shankar, you have it on the screen, the prospective study, but we had, because Upendra was doing it, I have plenty of other studies which I can share with you, where up to 6 months later, people have shown that they have better results with conservative treatment. Before I come to others in the panel, right? I'm at the Indian Spinal Injury Center and we deal with spinal injuries, and many of you deal with spinal injuries, but we have a very strong focus on rehabilitation also. And if Mr. Masri, who is the stalwart of conservative treatment, he too says, if you have a grade 1 power, right, you should always be able to encash on it and build it up further. But you may say then you can do that with conservative treatment also. In our experience, if you decompress, remove the pressure, if you have grade 1 power, you have a good chance to build it up. The problem comes when there is power 0/5 and no sensation and presents to you at 6 months after. So that is where the challenge lies. But Arun, you wanted to say something, comment something. Please unmute yourself, Arun.
Just a small point. Whenever you are considering surgery or non-surgery after a delayed presentation, it is important to get a fresh MRI to see actually whether there is a remnant disc there which is still causing pressure. Surgeries, delayed surgery, I believe in. I have operated even up to 9 months or 1 year with better outcomes with after surgery. But fresh MRI, do not believe a 6 weeks old MRI also.
Yeah, this is a slightly difficult topic because there will not be much literature, and I'm sure the panel will differ in this regard. But somebody with a foot drop who needs to walk either with a splint or with an ankle fusion later, if you can give him a guarded prognosis that, okay, there is a chance that your 2/5 power may become 4/5 or 5/5, but we will move on in the interest of
Dr. Chabra, I have a point. I agree with Arun. In the situation, there may be a situation where the disc herniation has done its job, damaged the L5 root, and disappeared. So there is nothing there to operate. So there is no disc lying there. It has done its job of causing neurological deficit and gone away. So
that
is one more reason why you should do a MRI.
Yeah, only point, yeah, you have to do an MRI. Only point I want to make here is there is plenty of room to research and work on it, right? These people with delayed neurological deficits, and this is also...
If you get carried away by this Ono from Japan, you will operate even on a patient who is 24 months old foot drop. Foot drop. He gives about 1 out of 3 chance that this patient will improve.
Arvind, there are around 15 other studies I can show to you, right? But you don't need to go far. There's an ASSI multicentric study going on, and in September we hope to present to you the outcome of this studies. PIVD with delayed neurological deficit.
Yeah, we are part of it, sir.
So we should be able to then come out with it. And many times what we think is not actually what matters. So you have to come out with documentation and with research to show what actually happens. We may not be able to get a conclusive evidence from one study, but we need to move forward. Soumyajit, and then we move forward quickly. Soumyajit, quick
Just 2 caveats. First is, before we move on, first is delayed, painless foot drop, absolutely painless, acute onset, absolutely painless foot drop is not very common presentation of lumbar disc prolapse. The second caveat is if the patient presents late 3 months, 4 months, 6 months, have to do a recent MRI. Don't get carried away by the old MRI. And the third is, as I completely agree with you, is that absolutely zero power is something which is completely different with a grade 2 power or even a grade 1 power.
Yeah.
Dr. Kabra, there is a question from the audience that what is the role of CRP in determining the acuity of the disc, whether the disc is acute, subacute, or chronic? And so if the CRP is high, is there more chance that you would go in for surgery for a neurologic deficit because you might think it's an acute deficit?
Rishi, quick answer.
No role for CRP, sir, as far as I know.
Agree. Nobody from the panel would disagree on that. Now, Gautam, if you can have the results of the earlier participants poll also, but we move on to the next participant poll. A 35-year male patient with acute low back pain and right leg radiculopathy and right L5 dermatome presents to your clinic with MRI showing massive lumbar disc herniation L4-5. Which of the following symptoms will be the key factor, or which of the following symptom will be the key factor in determining the management? Strained voiding or urinary incontinence, weakness of legs, L4 3/5, severity of back pain, or the duration of symptoms. So that's the participant poll. We will come to that, but I think in the panel, do we have any difference of opinion? Shankar, your answer?
No, I think this is a typical cauda equina and so needs surgery.
So that is the only absolute indication for a surgery. I think we wanted to let that message go out loud and clear to everybody. Now, my real question is, do we have a definition of massive disc prolapse? Upendra?
Once we see that more than 60-70% of the spinal canal is completely occupied and we are not seeing any of the CSF and the roots are completely displaced to a small thin layer, probably we think of a cauda equina syndrome because most of the rootlets are compressed there.
Massive disc prolapse, disc prolapse. Right? Now, anybody from the panel has a different definition? So if none, see, but there are two schools of thought where you talked about the canal compromise, right? But there's another school of thought which says that rather than only the canal compromise, you see the dural sac morphology due to the prolapsed disc, right? So you would say mild if the sac compromise is less than 1/3, moderate between 1/3 and 2/3, and severe over 2/3. So there are two schools of thought, and we need to take into consideration also that it's not only the canal compromise, but what is the dural sac morphology, which may be important. Now, this question to the panel: what is the first evaluation we should do to confirm or rule out the diagnosis of cauda equina syndrome in a case of lumbar disc herniation with history of bladder disturbance? So, Shailesh?
Yeah, as rightly mentioned here, I think the first evaluation is always clinical. It's a perianal sensation and voluntary anal contraction. This is the first thing which we have to do. There is no second best possible answer for this.
So this message should go out loud and clear, especially to all our orthopedic surgeon colleagues who are there, that never forget to put in a finger or have a finger put in to check the perianal sensation or voluntary anal contraction. This may be the single most important factor which may determine how you manage a massive disc prolapse or a disc prolapse per se. And so this needs to be done. Now, what is the first investigation we should do to confirm? So what would be the investigation you would do?
It would be the post-void ultrasound.
Yeah.
Post-void ultrasound.
That is the most
Suppose Suppose that shows that there is a significant residual, then
So 200 is the cutoff.
70 ml. 70
70
ml
ml, it rules out Coda equina syndrome.
rules out, but there are n number of other reasons for having a high post-void, like there can be prosthetic.
No, so then you have to classify Coda.
Right.
You'll have to classify it as incomplete and retention. So if it is more than 200, then it is retention. If it is less than 200 and if the patient is still symptomatic, then it is incomplete. Therein you still have to rush in based on the symptoms.
Anybody from the panel has any different opinion? Swamiji?
So, residual volume in the urine, my urologist colleagues tells me, is an extremely crude method of assessing bladder function so far as neurology is concerned. If you have to really diagnose a neurogenic bladder, there are a host of investigations, including uroflowmetry, UDS, and all that. But the problem of these other investigations regarding uroflowmetry and urodynamic is the fact that they need to have sterile urine in the urine system before doing that. So, as a screening test, ultrasound with a residual urine is good enough, but definitely not as a definitive diagnosis of a neurogenic bladder.
So we've been working on this for a very long time, and we published this in the European Spine Journal. So you are welcome to see this, and we came out with an algorithm. So just an post-void ultrasound or just a perianal sensation, voluntary anal contraction can't be enough. So if the post-void is high, right, this is the algorithm that we have published, right? You have these symptoms, you go in for a uroflowmetry along with ultrasound, post-void residual. Both are means non-invasive, right? And if there is a normal flow, no post-void residue, more than 70 ml, you go in for conservative, right? However, if Euroflow or the ultrasound post-void suggests that you need to evaluate it further, then you go in for urodynamics. And if there is acontractile bladder, you still can't say that it is a Coda equina situation due to the disc. You remember you should be aware that most of these patients are on pregabalin and other neurotropic drugs, and pregabalin per se can also affect the bladder. So then you will need to correlate with your perianal sensation and voluntary anal contraction. You may have the scenario where there is a acontractile bladder with a normal perianal sensation and voluntary anal contraction, and here if you stop the neurotropic drugs, many of them will recover. You need to reevaluate them soon. But if these are affected, then you would go in for a decompression. If it is a hypocontractile bladder, again, you need to rule out other causes like pain or drug induced. And if they are conservative, but if you find high PVR, along with it, you would go in for emergency decompression. So if it is normal, then still you need to do serial examination. So please go through this article. You'll find it very useful. We work closely in tandem with our neurourologist. So I would want to make a difference between a urologist and neurourologist. We have the advantage of being a spinal injury center, so we evaluate bladders a lot, and so we have a vast experience in this field. Now,
the problem, Dr. Chabra, is that most centers will not have an urodynamic study available to them at all, or some of the people who have it will not be able to do it in an emergency, whereas you want to operate in 24 to 48 hours. So,
Gautam, if they are interested, I can teach them low-cost urodynamics, which can be done with just a simple IV set and a IV stand, right? So, because we deal with spinal cord injuries, if people are interested, otherwise you can always refer them to an adjoining center. If you're working in a tier 1 or tier 2 city, you should have urodynamics available to you. So rather than blindly taking every patient who is training, you will be surprised the large number of patients who will turn out to be due to prostatic hypertrophy or other. And in our study, if you will find out, we could save surgery in a large number of cases who were not actually having a cauda equina due to a disc prolapse, right? So it is important that we evaluate them properly. See, 27% were treated conservatively by addressing, right, the cause after UDS suggested non-neurological causes, and 27% is a very large number. So we should take that into consideration.
Did they not have a perianal loss of sensation, the 27%?
27% were those who, see, perianal sensation is a very subjective. If you get your perianal sensation tested by 5 different people, you may have different results. So that's why we get our perianal sensation and voluntary anal contraction tested only by our bladder team, which does this inside out, say 50 times a day for our spinal injury and other patients as well. So you can't rely just on subjective phenomenon. You need to have an objective evidence for something where you need to decide for go in for a surgery. And so if you can save surgery in quarter of a patient who will not improve after surgery because that was a wrong diagnosis of a cauda equina syndrome, I think that is significant.
Dr. Chhabra,
Yeah.
Dr. Chhabra,
Yeah.
by talking about ultrasound, what I meant was it has a, so suppose the urine volume is, residual volume is less than 200, there is a 97%, very high chance of a negative predictive value. That's what I meant. I didn't mean it is diagnostic of a retention.
Yeah.
If it is less than 200 ml, there is a close to 100% possibility that it is not, a case of retention because of a cauda equina. That's what I meant.
Right.
But Arvind, only ultrasound itself is too crude and too simplifying.
Not a probability, a negative predictive value.
What I'm saying is we used to 10 years back, before we had access to the urology team, we used to put a lot of stress on even on evaluating patients after surgery. How is the residual urine volume doing? And I've been educated on multiple times by our urologists that this is an extremely crude, and there are so many multiple factors which can play into interpreting residual volume.
I'm not talking about more than 200 ml. If it is less than 200 ml, you can rule this out. That's what I meant. And at that point of time, you'll have to go by your clinical judgment in the absence of all the diagnostics that is available.
I think the point is well taken, Arvind. We have to move ahead. We are losing time.
No. Just I will answer Arvind's question. Arvind, we work in a spinal injury center and we have people who are complete paraplegics, who will void, right, and who will have a residual pressure less than 70 ml, complete, with complete bladder involvement because they void by abdominal straining. So just an ultrasound can't be taken into consideration, as Swamijit also pointed out. Let's move further. Now, can cases of massive disc herniation show long-term clinical improvement with conservative management? Quick answers. Shailesh? Yes, no. Unmute yourself. Shailesh, unmute yourself.
Yes.
Yeah. Is there an acceptable risk of nerve damage or cauda equina syndrome resulting from conservative approach in massive disc prolapse? Shankar? Swamijit?
No.
Yeah, Shankar?
Is there an unacceptable risk of nerve damage or cauda equina syndrome resulting from conservative?
In massive disc prolapse.
But I think it all depends. You can't have a yes or no answer in this.
Fine. No, but if a patient asks, you have advised me conservative treatment, is there a more than acceptable risk that I will get a cauda equina in this regard? So you will say, I can't say.
I can't say.
Swamijit?
I can answer this.
Yeah, Gautam. Was it Gautam?
Sir, can I say something?
Yeah.
A massive central disc prolapse has as much a good chance of improving conservatively as does a small disc prolapse.
Right.
Therefore, there are very good studies which have shown the natural history of a central disc prolapse. And if you do an MRI 6 months down the line, the central disc reduces by about 66% of its volume.
Right.
And if you do a 2-year study in these patients, it has been clearly shown that almost negligible amount of patients went on to develop either nerve damage or cauda equina. So no, it is not an unacceptable risk. You can definitely do conservative approach.
Thanks, Gautam. You have answered the next question also, so that's good. If surgery is well warranted, what would be the most appropriate procedure? Discectomy alone versus discectomy and fusion. So, Swamijit?
So that depends on how much of facet joint you are resecting and how much of disc space apposition is already there. If it's a collapsed disc space,
without compromising the stability.
If it's a collapsed disc space to start with a lot of degenerative changes without any major mobility in the disc, a discectomy fusion with a big laminectomy alone is enough. But if it's a tall disc space with facet fluid or with a lot of movement of the disc prior to surgery, and if I have to take out a lot of facet joints for removal of the disc, I would fuse.
Right. So we had the right answers from the panel. They can respond to conservative treatment, can respond well to conservative treatment. There is no unacceptable risk of nerve damage, clearly pointed out in the literature. Most of the times they will get resolved, as you can see here, right? And
Dr. Chabra, there is a question from the audience that when you have these kind of large, massive central disc herniations, there is also a large annular tear.
Right.
So what is the risk, number one, of recurrence?
Recurrence.
Is it higher? And number two is, can we use something like a platelet plug to block the annulus in these patients? Is that helpful?
So anybody would want to answer that quickly?
Yeah, I can take this one.
Yeah.
So the incidence of recurrent disc is close to 15 to 21% with a large annular disc, large annular tear with a massive disc prolapse. And these plugs and barricades don't work. There is some research going on. We discussed this before. It's all experimental, and it is those publications are all there is a vested interest behind them.
Yeah, from whatever literature review we did about recurrent disc herniations, the incidence of recurrence did not seem to be higher with massive disc prolapse, but fine. So we...
Then this is literature.
Right, fine. Now, cauda equina syndrome, like neurological deficit, is there a timeline after which we will not intervene? This question again to the panel. So, Rishi?
Yes, sir. Hello.
So, is there a timeline after which you will not intervene?
There is no specific timeline. We can say only the chances of recovery, like if we operate the patients within 24 to 48 hours, the chances of recovery is much better. But generally, like the study earlier quoted by Dr. Upendra, in that we included patients who had features of cauda equina syndrome too, along with bladder bowel. They had a neurological deficit in the lower limb musculature too. So some of them, even after 2-3 months, when they presented with cauda equina syndrome, they did show some recovery in their bladder function. So I don't think the time alone should be a factor after which we should not say that you don't benefit from surgery.
Yeah, and in our country, especially, most of them will not come within this timeline per se. But there has been enough evidence also that these time points actually do not reveal prognostic points. Not 1, not 2, not 3. There are plenty of studies which have shown that it's not 48 hours, which was initially felt, but if you do them even later, right? So as with this systematic critical review, they concluded that there is no strong basis to support 48 hours as a blanket cutoff time point to delay surgery, right? So you can, if the patient presents to you late also, you can go in for surgery with good results in this. But again, the key is if they present to you earlier, you may have better results. But something like bladder and bowel control, even if you have a moderate chance that they will improve better with the surgery, I think because we work again with spinal injury who do not have control, we know the importance of how these patients yearn for getting bowel bladder control. Anybody from the panel would tend to differ?
Dr. Chabra, there is a question from the audience
Yeah.
that how do you assess the recovery of bladder function post-operatively? Do you just judge it clinically? Patient says, I'm better, leave it at that? Or do you keep on doing ultrasounds to check things? Or do you keep on doing urodynamic studies over and over again? How does it?
See, you don't need to get an ultrasound done to check a post-void residue, right? These people who have a bladder involvement are generally put on clean intermittent catheterization. Once they start voiding on their own, you still suggest that you do an intermittent catheterization. After that, you put in a catheter and see what is the residual urine, because otherwise that may cause back pressure changes if you don't remove it. And you continue to do so till the residual urine comes to less than 70 ml. So you can, if needed, go in for uroflowmetry, post-void ultrasound or other techniques. But we have a team where we have a urologist working with, neurourologist and bladder nurses working with us. But we have a good protocol, and this has been mentioned also in that article in European Spine Journal that I mentioned about. I would strongly recommend that you go through that article. All your answers, all your questions will be answered there. Now, next question. Cauda equina syndrome, a patient is there. Now, would you go in for a laminoforaminectomy? There is a massive disc herniation. Or would you do a laminectomy? So, Gautam, would you want to take that question?
So generally, if there is a cauda equina syndrome with a large central massive disc prolapse, then I prefer to do a laminectomy, do a wide decompression, and without having to remove the disc tissue without much retraction of the neural structures. Sometimes a partial cauda equina syndrome is seen when there is a large posterolateral disc prolapse. In these patients, I tend to do a hemilaminectomy or a laminotomy, and I would go ahead and do a discectomy. But generally, for a large central disc, I always prefer a laminectomy. The main goal is you should not end up doing more damage than what is already there.
Gautam, and that becomes particularly true if there is some perianal sensation preserved, because there is a good possibility to recover, but the cauda equina is under severe pressure, and minimal handling can tip the balance, and they can the patient may wake up with no perianal sensation. So something like bowel bladder control recovery is very important. So generally people would tend to ensure that they don't wake up worse than what they were before, though you can't assure that. So Gautam's point is well taken. There is this other patient with low back pain since 8 months, left leg pain since 3 months, pain in the left L5 dermatome, history of lifting heavy weights 8 months ago, low backache aggravated by walking, relieved by rest and medications, and no bladder and bowel involvement. So that is the neurology. There is SLR is positive, both sides. No, so you can see on the X-ray there's a slight antrolistesis grade 1, which is unstable on an X-ray, right? You can see a disc along with it. CT scan. So has failed conservative treatment now. So what would be the management? Anybody from the panel? Shankar?
Yeah, normally in these patients, I would counsel them well and I would offer them primary fusion in such cases.
Good.
So,
anybody would differ on this? Anybody from the panel? So in patients with spondylolisthesis with a disc prolapse, are there any special presentations, difference in presentation, or do they behave other than pain being equal or more than the leg pain? Is there any other difference? Arvind, you wanted to comment something.
Yeah. So this is quite straightforward then, but sometimes you get tricky patients. So patient has L5 radiculopathy, of months duration, and there is associated, foot drop. It's about grade 3. and there is a massive L4, L5 disc herniation on the same side, and patient has a long-standing L5S1 lytic listhesis.
Right.
Even that causes L5 pain.
Right.
So at that point, what would you do? So this has been witnessed at least 2-3 times.
Right. So quick answers from you. We are running short of time. What is
If
the
in our center, if it is purely radiculopathy, we tend to address only the disc herniation. We don't do because if we plan to do a fusion, then it has to be an L4 to S1 fusion, which will be a bigger undertaking. But if a patient has been having chronic back pain before the onset of this new onset radiculopathy, then we counsel the patient and get ahead with the fusion.
Anybody else would differ on this?
No, regarding this case, I just would like to add up that when we see such young patients with some amount of translation, 3 millimeter, 4 millimeter, listhesis, black disc, localized kyphosis, maybe minimal kyphosis, which we can see, it is better to go for a primary fusion than going for just decompression, because we are landing up in trouble for a recurrence or things like that.
Especially if there's significant back pain, right?
Yeah.
Dr. Chabra, there is a slight twist to the scenario. If this same patient was 67 years old, had a grade 1 listhesis, but the disc space had collapsed, there were osteophytes also there, and now there is a disc herniation, would the approach still be the same? Would people still think about doing a fusion, or would there be a microdiscectomy would be reasonable to be doing it?
Shankar Gautam presentation may be different here. The patient may not have instability, most probably. It may be a degenerative spondylolisthesis which may be stable. Generally, they are stable, and most of the times you can do just with the decompression and you don't need to fuse. I would not do that if it is stable and if the back pain is not significant. Anybody from the panel would differ? So,
can I answer that, sir? Can I add a small point? Yeah. So if there is an extruded disc through the annulus, when we need to go into the annulus and remove more discs, then we may add more instability to that situation. So in that situation, we may need to consider a primary fusion. If it is only a small sequestrectomy and a decompression, then we can get ahead with without a fusion.
Okay. Now, this displacement in patients with spondylolisthesis is predominantly in cephalad and lateral direction. So it accounts for the exiting nerve being more commonly affected than the traversing nerve route. So in spondylolisthesis with disc prolapse, this is generally what is there. You would generally have degeneration also with spondylolisthesis, and they would also tend to self-stabilize. And you have a large number of these discs being pseudo disc bulge without disc herniation in ischemic spondylolisthesis. So just a disc bulge in a spondylolisthesis doesn't mean that it is a true disc bulge, and very often in the remaining it would be an extreme lateral disc herniation or a sequestered upwards disc herniation, as we mentioned above. Now, other than instability, your indications for fusion in a case of prolapsed intervertebral disc, Somijit?
Hello.
Yeah, Somijit.
So, as I said earlier also, young patient, single level disc degeneration on a single level dark disc, tall disc, back pain more, if not equal to leg pain and a high demand back. These are my indications of fusion. Otherwise, with a smaller disc, not so high demand back, but I can get away with a microdiscectomy. There is no instability, collapsed disc space, elderly people, all my patients would not be undergoing any fusion.
Yeah, my indications used to be the same, Somijit, till I realized that sometimes it can be the disc because of the back pain, right? So then I started doing interspinal stabilization, dynamic stabilization patients after endoscopic discectomy. I found good results. Then I also stopped doing any stabilization and I still got good results. So we may differ. Sometimes the back pain may be due to the disc itself, but you need to counsel the patients well that if you are you may still have persistent back pain after the discectomy, and if they are ready only, then you would take that chance. Anybody from the panel?
So just one comment. This goes for all of us, all of panelists together. that what we are dealing with is a cascade of degenerative events. The way it will behave in the next 10 years in a particular patient is something which is completely unknown to us. So we
Yep.
are intervening at a point in the on the life history of a particular patient without actually knowing what it is going to be the next 10 years. So whatever we say and do to the patient must be an honest submission of accepted facts. That's all, but it can definitely go wrong.
Yep, Swamijit, except that many of us have a more than a 10-year experience and our patients would have, many of them may not come back, some may come back if we have, in our 25 years experience, if we have handled some patients. So in the literature, we'll find number of indications for stabilization. For me, they're totally different. For me, most of the times it's just instability where we go in for it, even in massive disc herniation, have stopped fusing per se. But of course, I think we can have a separate discussion on this per se. Gautam, did you want to say something?
No, just a question from the audience that if a patient has spondylolisthesis with slip disc, grade 1 or grade 2 spondylolisthesis with a prolapsed disc, and obviously you have decided on a fusion, what is the difference between doing an interbody fusion, that is like a TLIF, or a posterolateral fusion? Are the results different? Is it wrong to do a posterolateral fusion in these patients? What would be the audience, a panelist's opinion?
So a quick answer, Upendra.
Basically, you are going to take out the disc for decompression. So you have to do a interbody fusion there. So anyway, you are doing the instrumentation and the posterolateral fusion. Along with that, for decompression, once you are doing the disc work, you will be doing an interbody fusion. So we there.
Anybody from the panel differs?
So there has been an excellent publication way about 15 years back by Madan and Bueri, in which they picked up 49 patients, 24 of posterolateral and 24 of interbody with low-grade latex listhesis. And they could show that for interbody fusion, the radiological evidence of fusion was better, but clinically there were no difference at all. So for a low-grade spondylolisthesis, it hardly matters whether you do interbody or a posterolateral, but if you are reducing, it is mandatory you do an interbody. Otherwise, it
that is a totally different etiology. Here you are doing annulotomy, you are emptying the disc. The indication is different here.
Also, Swamijit, if we are changing the kyphotic angle, of course, there will be reduction in that case. So if we are reducing the kyphosis, or if it is in kyphosis. So if you are fusing in situ, I think the results for intertransverse are as good as interbody. But this is also again another topic of debate which has been going in for a long time. And as I have summarized in my 2 slides also, though there are level 3 and level 4 studies with regard to fusion, but still outcomes in patients without instability, outcomes have been good per se. Now, this is a patient with a low back pain and bilateral lower limb pain for quite a while. Weakness in both lower limbs since 3 months. Inability to walk since 3 months. Loss of bowel and bladder control 1 month. No medical comorbidities. You can see the muscle chart there, right? Perianal sensation is reduced. Voluntary anal contraction absent. You can see the X-rays here. See the X-rays here. You can see the X-ray. So it is an L2-3 disc prolapse which is there, right? You can see the axial sections. See the axial sections. So management. So basically, I put the question straight, right? Shankar, you would do a discectomy. Would you just do a discectomy? Would you fuse? Would you go in with a prefixed decision, or could your decision change on the table as well?
No, I normally would fuse a high lumbar disc with such severe symptoms.
Right.
So I would do a laminectomy and do a fusion.
Anybody from the panel differs? Right. We used to do the same, and I can show you a number of cases where we used to put in screws, because there are various publications which also show. So these are 2 cases where we have done it without any fusion, and we have had good outcomes. The reason why you would fuse is because of the different anatomical characteristics, right? Because the distance between two pars interarticularis is narrow, inferior border of the lamina overhangs most of the disc space, diameter of the thecal sac at the upper level, lumbar level is larger. And so you would be hesitant that either the pars gets affected and you create instability, or you, in the process of retracting, you may cause further neurological deficit. So these were our indications for fusion initially, but now we tell the patients that on the table, if we feel that we have created instability, we may need to fuse, but if we feel that we are able to remove it safely, remove the disc safely, we will just do a discectomy. And as I have shown in these two cases, we were able to get through without any fusion. Of course, I can show you a large number of patients where we used to fuse before, but we try to conserve as much now, including one that we did around 10 days ago. Yeah, Shailesh, quick answer, quick comment.
Sir, yeah, I agree with you. At L2-3, maybe we can definitely get away. But at L1-2, we personally prefer to definitely fuse because it is very close to the conus. We approach from a lateral aspect, rather than going directly from the posterior aspect. So at L1-2, we are little reserved about only decompression. L2-3, we are okay.
Yep. So quickly saying that upper lumbar disc, there is no clear definition, but approximately 5% of lumbar disc herniations are upper lumbar disc, especially if you consider L1 to L2, 3 as upper lumbar. And then you may have a difficulty in diagnosing because they do not innervate any specific muscles, but then pain will be on the anterior thigh in many of them. And so femoral stretch test will be positive for our orthopedic surgeon colleagues. And a single disc herniation at higher levels can cause affect multiple roots, as was in our case, because all the roots are there. And significant cross innervation between spinal nerves in the upper lumbar region may account for polyradicular presentation in upper lumbar discs. So as we discussed, people tend to try to avoid fusion. There may be a differential diagnosis also of a femoral mononeuropathy or retroperitoneal hematoma, ruptured abdominal aortic aneurysm, as Guru demonstrated in Delhi Spine Society meeting yesterday, or in retroperitoneum. And endoscopic approach, Arun will say, that works very well in such patients, but otherwise you could go in open as well. Endoscopic, especially because you can go laterally and you can remove the disc without the need for a fusion per se. So these are some of the points. So studies have shown that you can safely do it without fusion also, just with a discectomy, and that's also what is our experience. Now, quickly, in a scenario of a lumbar canal stenosis, as Rishi, you were talking, with a disc prolapse. So this is a case with a weakness in bilateral lower limbs, bilateral leg pain and heaviness problem increased from past 1 year, walking only few steps with the help of support. And this is the neurology, as you can see. This is the X-ray. It's an interesting case because, as you will see, again, there is a canal stenosis at L2, 3, L4, 5, maybe L5, S1, but you can probably also see here a meningioma, right? So this patient presented to us. You can see that there is canal stenosis at multiple levels. And there is a meningioma or a neurofibroma, whatever. It could be either, right? So what would be the proposed management? Quick, Shankar, what would you do?
I will just deal with the lumbar canal stenosis and counsel the patient about the meningioma and tell the patient whether you require it or not at a later stage. So I have lots of patients with meningiomas going around and I have not operated on.
So that's what we did also. If anybody from the panel differs, the real question is that if there is a disc prolapse which is contained, right, which is not sequestered in a lumbar canal stenosis, will you touch the disc or will you just do a decompression? That is my question to the panel. Arvind?
Yes, so you'll have to look at the morphology, and if you all have to see whether the symptoms have suddenly aggravated. Patient was having a standstill symptoms, and suddenly if there's aggravation, you can reason it out that that herniation must have worsened it. But otherwise, if it is a chronic, progressive claudication that is compromised, so then I would just do a decompression alone.
Yeah, the other thing, as you mentioned, but probably you did not highlight, was whether it is claudication or radicular pain. That may also make a difference whether you choose between removing the disc or just doing a decompression. Any of the panel has any other suggestions? So we do not have a lot of publications in this regard. This is again, there is room for a lot of research in lumbar canal stenosis with a disc herniation. But you may have a situation where there's a post-decompression disc herniation in lumbar canal stenosis. And they have shown that if there's preoperative retrolithesis more than 3.1 mm, and this was found to be the sole significant risk factor in a post-operative, post-decompression lumbar disc herniation. So in this case, you should not go in for extensive destabilization of the posterior limit. You shouldn't do that even otherwise, but as long as you can do, you may not do go in for a laminectomy, laminoforaminotomies per se. You preserve the posterior spinal structures, it would be good. So coming to the last case, 2-year history of low back pain, progressive bilateral buttock and leg pain, L5 and S1 dermatomes, VAS 7 by turn, perianal numbness for past 2 months, refractory to conservative treatment, strained voiding, loss of bowel control, and inability to walk more than 30 feet for the past 15 days. You can see the neurology which is affected, reduced perianal sensations and voluntary anal contraction. Urodynamic study revealed a hypocontractile bladder. And you can see the prolapse disc here. Management. Does this MRI, see, I'm trying to tell again, we have published this case also, right? Can the MRI get you to think something else? So when we went in and did a L4 hemilaminectomy and flavectomy, noted an unusual protuberance and possible adhesions between the dura and ligamentum flovum. We noted a defect in the dorsal dura with discogenic material herniating from the defect and no obvious CSF leakage. So dural tear was extended by durotomy. So it was an intradural disc. So why I put this case as the last case is people should be aware of this pathology, and you should read your MRI quite well. And there are some signs, so if you would want to go through the case that we published, but even otherwise, which may suggest that you can see here how the disc was spouting out of the posterior dura, right? So, and so you can see the defect here also. And we extended the rent, we removed. And we removed the disc. But we could still feel that the pressure had not been relieved fully from over the rootlets at that level. So we explored further what was being told by Gautam Shankar, right? We found a large osteophyte complex, right, which we chiseled out transdurally. We had to chisel out transdurally. with care taken to protect the cauda equina, right? And it took us quite some while and a lot of blood loss in these patients. So if there is a breach in the continuity of the PLL and if there is a complete CSF block, so there is a sharp beak-like appearance of the extruded disc, what they call as the hawk appearance. If the contrast MRI reveals a crumbled disc sign, so there's a compact region at the disc level which shows enhancement, but there's a less compact peripheral disc with irregular borders and no ring enhancement, right? So this would suggest that you may have an intradural disc per se, and this patient recovered gradually and had normal bladder and bowel control. So any comments from the panel on this? Anybody has faced similar scenarios? We have quite a few cases of intradural disc, but this one had migrated through the anterior and the posterior dura and was facing you as you entered into the canal. So anybody has any other similar experiences from the panel?
We had one, it was a 3 months old bilateral foot. It had come out through the dorsal dura, were rootlets there without any CSF leak.
Right.
Luckily, we didn't have any calcified disc there, so we could get away without fusion in that, but we did a laminectomy and complete decompression in that.
Right, right.
And that patient improved actually, foot drop improved. So yeah.
So here, because we had to destabilize because of the big osteophyte and everything, right? So we had to do the fusion, though we had not planned to do it initially. So anybody else has any other last comments on this case?
Yeah.
Yep.
Yeah, we also had one experience of such a large disc and intradural extension. There was a tail which was going inside the dura, and that's where we realized intraoperatively that we need to go in. And we did a transdural similar, but luckily, as in this case, if you see in pre-op MRI also, there is some amount of kyphosis at L4-5, and the disc which is come out, the hawk sign what you're talking about, where you need to fix. But in the case which we had was a very good lumbar lordosis and that only fragment which we had to remove. But similar experience, you have to do a durotomy to take out the complete disc.
Right.
Dr. Chabra, 5 minutes, please.
Yeah, 5 minutes, Gautam. So I was about to ask you that. Now, quickly, can someone summarize what are the factors influencing outcome in prolapse intervertebral disc as such, and also when you go in for a surgery? Soumyajit, would you want to say something?
Important factors in influencing the outcome is a clinical decision making and its correlation with the MRI. This statement cannot be overstated because this is the crucial important statement for treating all patients of lumbar disc prolapse. It is an important clinical judgment. That's a clinical evaluation which is extremely important, and that has to be matched with the MRI. Second is we all should try to understand and discuss with the patients the natural history of the problem and look at it in a view that the natural history of these problems is very conducive and most of these patients can be treated conservatively. Finally, having said that, the small percentage of patients who would require surgery need a conscious judgment regarding the available literature, your own experience, and the requirement of the patient in his particular societal structure, what is the best sort of treatment. And then you should plan the treatment accordingly.
Shankar, do you want to add anything? What are the factors influencing outcome?
I think there are many factors, and summarizing basically is the important. I think this session, the initial session was on the conservative management of disc prolapse, which Basu has already said most would resolve conservatively. However, there are many types of disc prolapse and many factors affecting outcome, and that is important to say. So where is the disc prolapse? What is the patient's symptom? What is the clinical correlation? What is the neurological deficit? What is the instability sign? How does the facet look? What is the disc height? I think all these play a major role to play. Does the patient have any bladder bowel symptoms? Does the patient have cauda equina? So as you clearly pointed out, a lot of cauda equina is done unnecessarily where the symptoms could be of something else. So I think the clinical correlation with radiological examination and looking deeply and very intently into the MRI and X-ray pictures along with clinical correlation is very important.
Right. Rishi, any factors which affect the outcomes of surgery? Unmute yourself, Rishi.
So I think both Dr. Basu and Dr. Shankaracharya has nicely summarized. To add it, so patients who are smokers, so we should advise them strictly that smoking has a significant negative with respect to the outcomes of the patient. And apart from that, obesity. So obesity has been associated with a slightly higher rate of recurrences and chronic back pain after discectomy surgeries. And that's it, sir.
So the L5-S1 and L4-5 disc herniations have better outcomes after surgery than the upper lumbar disc herniations or far lateral. Sequestered or extruded lumbar disc herniations have better outcomes. And those which may result in less satisfaction and poorer outcome scores are contained disc herniations, predominance of back pain, those on restricted duty, right, and smokers. So in US, when I was there in 1994, nobody would touch a disc till they would have them evaluated very well by a psychologist. So they would have a psychological evaluation and have it certified that it is not the psychogenic pain before they would do a surgery, right? So,
Dr. Chabra, can I interrupt?
Yep. Sure, Gautam. I'm through.
The incidence of failed disc surgery is almost 15%.
Right.
And the most common causes are very poor patient selection.
Yeah.
Number two is in incidence is even if you have selected the patient well, is then to select the correct procedure.
Right.
And only a few patients fail because you have not executed a proper procedure surgically very well. So we are always worried, oh, this guy has to be a good surgeon or a very good surgeon. That is necessary, but he has to be a better clinician in able to judge which patient is going to do well. And the key thing here is always one single word: clinico-radiological correlation. You must have a good clinico-radiological correlation. If the history and the examination findings do not match the MRI, please do not touch the patient. You are going to land up in problems. You must understand things like there are often a situation which I call as the sucker disc. By that I mean only people who are suckers operate on such discs, because these are discs which have a broad annular disc bulge. Patients have some back pain, goes to a spine surgeon or an orthopedic surgeon. He gets an MRI done, shows a broad base disc, and he goes and operates on the disc. These are patients who are bound to not do well. So important thing is first select the correct patient, rule out other diagnosis. A very vital point brought out by Basu earlier was that if there was an acute L4-5 disc prolapse and acute foot drop, which is painless, the chances that this is because of a multiple sclerosis and acute attack or something or a Guillain-Barré is much higher than having a patient who has got a lumbar disc prolapse. The similar thing was brought out by you when you presented the findings of your study of urodynamic study in cauda equina syndrome, where a large number of patients were actually not patients of cauda equina syndrome. That of course should have been ruled out clinically. So this is the most vital, important message we deal with. Along with that, just to conclude, since the seminar is finished, I would like to firstly thank Dr. Chabra for the excellent comparing that he's done, and thank all the panelists who have done a wonderful job on today's seminar. I would also like to remind our audiences that there are 2 more webinars coming up. The next one on the 5th of July is on cervical myelopathy, and on the 19th of July is on lumbar canal stenosis. So please join us for these two webinars. I would also encourage all those of you who are IOA members but not ASSI members. This is the time to get onto the ASSI bandwagon, become a member. You can write to me if you want to be a member. My WhatsApp number is 9820504351. I'm Dr. Gautam Zaveri, Joint Secretary of ASSI. Or you can write to the ASSI Secretariat, which is assi.secretariat@issconline.org. Finally, ASSI has come up with a series of
His voice went away. Did he disconnect?
I think we have lost Gautam.
I think he got disconnected. No, he's still there.
Gautam was trying to say is there are a series of monographs, and if any of you, there's one on the prolapsed intervertebral disc as well. So please, we would strongly recommend that you go through these monographs, which have been compiled by all the experts across India and are very good. You can have more information from the ASSI website, or you can write to the ASSI Secretariat, the address of which is there on the website of ASSI. If you want to contact, just go to the Contact Us tab and you'll be able to get through to us, right? So,
I just want.
We are losing you, Gautam.
Yeah, my connection is very poor today. So if you do listen me out, before I close, I would like to announce two things for the audiences. One is there is an ASSI monograph specifically on lumbar disc herniation. It will cover entirely what we have discussed in the last two sessions. And it is worthwhile buying this monograph. It can be bought.
I think, Chavra, you need to wind up.
Yeah. So I think we will, the take-home message for everybody would be PIVD is a common condition. Diagnosis is made through clinical presentation and evaluation supported by radiology. So as was being mentioned by Gautam and everyone, we need to have a strong clinico-radiological correlation per se. Conservative treatment is the mainstay. You may go in for surgery. There are various techniques available. Do what suits you best. But again, there may be some special considerations which we discussed today. So that would be our take-home message. And Gautam, are you back, or do we wind up?
No, sir, he is not back.
So with that, we thank you all for being there, and we hope to have you with us for our subsequent webinars. We have two series going on, one which would be a bit more advanced and the other for the common orthopedic surgeon. And we thank all the panelists who have taken time out. I think it was a very interesting discussion. And in the end, we would want to thank Neeraj Bijlani for letting us use his network to reach to all the people, and of course Ortho TV, which you represent. Thanks, Neeraj. Thanks a lot.
Thank you, Chavra. Thank you, Neeraj. Thank all the panelists, and have a great weekend. Bye.
Yeah.